Welcome to the TOEFL Listening section. In this section, you will listen to an academic lecture and then answer questions about what you heard. You may take notes while you listen. You will have time to review your notes before answering the questions. Listen to part of a lecture in a university class. You will hear the lecture only once, so listen carefully. After the lecture, you will answer some questions about what you heard. Some questions ask about the main ideas and supporting details. Other questions ask you to make inferences or connections between ideas. Answer each question based on what is stated or implied in the lecture.
Good morning. Today we will examine disease prevention strategies with a focus on vaccination programs and health education. I want you to think about prevention as a layered set of interventions. Vaccines form a biological layer by inducing immunity. Health education forms a behavioral layer by changing how people act and decide about vaccines and other risky behaviors. First, vaccines. Vaccination programs aim not only to protect individuals, but also to reduce transmission at the population level. For example, measles has a herd immunity threshold near 95% coverage. When coverage falls below that level, we see outbreaks. The global reduction in polio cases since 1988 is a testament to sustained vaccination efforts. But vaccines require infrastructure. The cold chain must keep many vaccines between 2 and 8 degrees Celsius from manufacture to administration. If the chain breaks, potency can be lost and the program fails even if people show up for immunization. Program design also matters. Routine immunization schedules, booster doses, and catch-up campaigns work together. For human papillomavirus prevention, school-based 2-dose schedules at ages 11 and 12 have been effective in many settings. Mass campaigns, such as supplementary immunization activities, can quickly raise coverage in an outbreak or to close immunity gaps. A classic case study comes from a low-income district where a combined strategy of door-to-door vaccination and school clinics increased measles coverage from 60% to 90% within 6 months. Second, health education. Information alone is rarely enough. Effective education programs are interactive, culturally sensitive, and use multiple channels. In one urban program, community meetings, radio spots, and social media were coordinated to explain vaccine safety, the benefits of herd immunity, and where to access services. That program measured a significant increase in timely vaccination appointments. Health education also involves training health workers. When nurses and community health volunteers can explain side effects, contraindications, and follow-up recommendations, parents feel more confident. We teach communication techniques such as motivational interviewing to address vaccine hesitancy. This is not scripted lecturing. It is active listening and guided questions that help people express concerns and reach decisions based on evidence. Integration is critical. Combining vaccination services with routine child health visits, nutrition screening, or school health programs increases uptake because it reduces missed opportunities. Integration also improves cost-effectiveness. When we evaluate programs, we look at coverage rates, incidence changes, and cost per disability adjusted life year averted. Prevention almost always yields large returns compared with treating disease. Surveillance links these strategies. Real-time surveillance identifies outbreaks where rapid response vaccination can stop spread. For influenza prevention among the elderly, we use seasonal vaccination campaigns timed to community transmission and combine with education materials about hand hygiene and staying home when sick. Addressing social determinants is part of prevention. Barriers like transportation, clinic hours, and indirect costs matter. Community outreach that offers mobile clinics or weekend hours can close access gaps. Equity-focused strategies ensure that vulnerable groups receive the same prevention benefits as others. Risk communication is another component. During an outbreak, clear, consistent messages about what to do and why help maintain public trust. Misinformation spreads quickly. Programs that monitor rumors and respond promptly reduce hesitancy and prevent declines in coverage. Finally, evaluation and adaptation are essential. We conduct cohort studies and program audits to identify weaknesses. If cold chain failures are frequent, investment in solar refrigeration or improved logistics is justified. If education sessions do not improve acceptance, we revise messaging or involve community leaders. Prevention strategies are dynamic and must be tailored to local epidemiology and context. To summarize, effective disease prevention relies on robust vaccination programs and well-designed health education. Both need operational support, including cold chain management, surveillance, trained personnel, and community engagement. Combining biological and behavioral interventions gives the best chance to reduce incidence and protect populations. Thank you. In our next session, we will examine specific evaluation metrics and design a short prevention plan for a hypothetical community.
Listen again to part of the lecture, then answer the question.
We teach communication techniques, such as motivational interviewing, to address vaccine hesitancy. This is not scripted lecturing. It is active listening and guided questions that help people express concerns and reach decisions based on evidence.
This concludes the listening section. For more TOEFL practice tests and study materials, visit Spinta.org.